Okay, as you know that we've been having patients that have CKDs, and there's studies that show that there's potential associations between PPI and CKD and all that. So I have a big populations of patients with tobacco use, like 40 pack years, and diabetes CKDs, who happen to have non-dysplastic Barrett's. We put him on PPI, and he has worsening CKD from stage 3 to 4. He's on nephrologist who DC the PPI and put him on H2 blockers. Now, my question is, are there any data that you know that show the benefits of PPI versus the H2 blockers in preventing esophageal adenocarcinoma? And would you recommend the H2 blockers in patients for the patient with non-dysplastic Barrett's and worsening CKD?
That's such an important question. I can't tell you how often my case managers actually get this call from patients on PPI therapy. But I think what is really important to understand is that causality between PPI and CKD worsening has really not been established. There may be an association with this. I will tell you that H2RAs don't work as well as PPI therapy. I did not get the chance to go over the systematic review that looked at all studies comparing outcomes in patients on PPI and H2RAs. The risk of progression is still much higher in patients who are on H2RAs compared to PPI therapy. So unless there's a compelling reason that you need to take that patient off a PPI, I would still make a strong case for ensuring that your patient stays on PPI therapy. And it's really astonishing how often these papers keep coming out about this association between PPI with some complications, dementia, cardiovascular risks, and so on and so forth. I think our goal is to ensure that we look at that data critically and address this in a very thoughtful manner with our patients and our colleagues.
Please.
I've got a couple of questions. They should be quick, though. One is that most of my practice, I do ablation, complete ablation in either low-grade or high-grade dysplasia. But I have done a handful of patients where it was a long segment, almost 12, 13 centimeters, and the patient is very worried about it, and so I have done complete ablation. But in one or two of them, after ablation, the Barrett's grew back right away within 2-3 months. Now, I have suggested to those patients that once I ablate them, I would like to have either fundoplication done, and a more secure way of saying that we are preventing reflux than trying to depend on PPIs. Of course, they may still need PPIs, I understand. My other question is about the visible lesions. Do you biopsy them extensively before resecting it? Is it like not the colon polyps that are flat, that you might tether them down?
Yes, so I think two really important questions that you've brought up in the management of Barrett's esophagus. I'll tackle the second one. I think that's easier. With regards to visible lesions, anything that looks raised or even abnormal based on NBI pattern is something that I consider as a visible lesion. My practice is not to take biopsies, but to proceed with endoscopic resection. But for folks who don't perform endoscopic mucosal resection, I think it's perfectly fine to take just one biopsy, or if you have a good relationship and you know that you can get this patient in to see your colleague fairly quickly, you can either not take a biopsy or just take one biopsy and send that patient to someone who does perform endoscopic mucosal resection. Taking a biopsy should not impact your ability to perform endoscopic mucosal resection. The second question is, or the first question is actually fairly challenging. We can spend almost an hour just talking about non-dysplastic Barrett's. I'll tell you what my philosophy is for non-dysplastics. I don't ablate non-dysplastic Barrett's. The only time that I have actually done that was an anesthesiologist, and I have done it up to 5 times. Anesthesiologist, family history of esophageal cancer, long segment Barrett's esophagus. These are the things that cross my mind, age less than 40, that's when I consider non-dysplastic Barrett's esophagus ablation. I think it does us a lot of good, and the patient too, by just bringing them to our clinic and just explaining that the risk of progression in non-dysplastic is extremely low. And I agree with you, long segment Barrett's is a risk factor for progression for esophageal cancer. But by and large, avoid ablation for non-dysplastic Barrett's. I've not seen this in my practice where the Barrett's grows back in 3 months. I'm sure this happened, but that seems like an anomaly, and it should not be happening if you've used, the standard approaches for ablation of Barrett's. And we can talk a little bit more about that at the end of the session too.
Microphone in the back.
I've seen it in the literature and I've seen it in the slides, but I don't understand what WATS is. Can you explain that?
I'm sorry, say that again?
WATS, wide
WATS.
area transit.
Oh, Watts. This is a novel approach to sampling patients with Barrett's. So I talked to you about all the issues with the biopsies that you obtain from Barrett's esophagus during surveillance. What this brush does is it really samples the entire Barrett's.
No.
No, it's a brush. It's an abrasive brush that you pass through the working channel of your endoscope, and you literally brush until you see red spots so that you know you've gone deep enough and sample the entire Barrett's. If you have a long segment, you may actually need 2 brushes to sample. And then this gets sent to a central lab. They analyze it, and they tell you if that specimen is just Barrett's, does it have dysplasia or not. So it may address this whole issue of sampling errors. As of now, you should, if you're going to use this in your practice, it has to be used as an adjunct to your Seattle biopsy protocols. It cannot replace your biopsy forceps as of now.
Last question.
Yeah, we talked about approximately a quarter of Barrett's epithelia not being associated with pre-existing reflux. What is the thought about use of PPI therapy in those patients who don't have reflux to begin with?
I'll give a short answer. Yes, you should still use PPI in those patients, even if they don't have symptoms of acid reflux, given the data suggesting the chemopreventive role of PPI therapy in progression to high-grade dysplasia or cancer.
Great. Sachin, thank you again for coming. Appreciate it.